Spinal Truth Show, weekly podcast edition. I'm your host, Dr. Caleb Slater, here with Chris, an expert radiologist.
That's what they say.
Just for the record, he is not an expert radiologist. Today's episode is going to be on understanding some of the common terminology that's given to you in the medical system, like disc bulging or military neck or slip disc, pinched nerve, stuff like that.
Yeah.
Before we get to that, make sure to like and follow us on TikTok, Instagram, Facebook, YouTube. We're on Spotify for our podcast as well as on YouTube. So follow us on those platforms.
So we're talking about imaging essentially and what some of these terms mean.
Yeah, some of the findings on imaging and some of the terms that get given to patients. And I think people need to understand how generic a lot of these terms actually are and how little meaning they actually have. So maybe we start with, how about herniated disc? What's a herniated disc mean to you, Chris?
Well, I think it means the disc is bulging in a way that is putting pressure on a nerve.
Yeah, so a herniation is a generalized term. Protrusion, prolapse, disc bulge, they're all types of herniations.
Okay.
And so a disc bulge can happen without any pressure on a nerve.
Right.
So can a protrusion, even a prolapse. So none of them need to have nerve compression. All it means is that the disc, which has kind of like a thicker gel-like structure inside of it, it's called the nucleus pulposus, but it's basically just like, if it's a jelly donut, it's the jelly inside the donut, right? That jelly is moving around a little bit and pushing from the inside out, making the disc bulge or protrude, but the material, for the most part, stays in the disc. So it is not slipping out, it's not seeping out, it's not, your disc isn't popped, it's
all still there.
It's all still there. The best analogy is a balloon filled with sand. If you squeeze down on one side, the sand goes to the other side, it makes it bigger, distends it. That can get in the way for this, in the body, get in the way of the joint, put pressure on a nerve, stuff like that, cause pain, but it stays in the balloon. Mm-hmm. And the cool thing is that if you figure out where it goes, if you squeeze down on that side, over time, you can actually move it back.
Yeah.
For the most part. So, and then the final thing for a lot of what we're going to talk about, and I'll probably mention it on every single one that we say, is that these are natural findings in your body, especially by the time you hit 40. If you don't have a degenerative disc, a herniated disc, one disc that has a protrusion or a prolapse, you're more in the abnormal category than the normal category. So these findings that get labeled as degenerative make you sound like you have a problem, where they're just natural. Just like you look different at 40 than you looked at 20. Yeah. So does your
Some
MRI. I'm still pretty close.
Yeah.
Except for the gray hair, the 15 pounds, the bags under my eyes, the wrinkled skin. Other than that,
it's just you're pretty much. If I squint a little bit, can't even tell the difference. But what I'm hearing so far, just from the disc herniation itself, is that there's a lot of things in there that will present on a finding, but not necessarily have an effect or cause a symptom.
Right. And so, you have to understand that these are normal, right? Again, I talk about the study a lot, but they took a bunch of people off the street, no pain, no symptoms whatsoever, did imaging on them, and they just found that most people had a problem. Most people had a herniated disc, spinal stenosis, facet arthropathy, spondylolisthesis. They had meniscus tearing or disc or labral fraying or something like that.
Yeah.
They had a problem, but none of them had any pain. So a lot of the problems that you find on your imaging, you're going to get this term that you don't really understand. You're going to be told that it's a problem, and it's not.
Well, isn't that the same as what we literally just said, where I'm the same as the 20-year-old, except for I got bags under my eyes and I got some wrinkles. Like, it's aesthetic changes, perhaps?
Right, yeah. It's aesthetic changes on your imaging, and it doesn't necessarily mean that you have symptoms.
Okay.
All right, how about another big one that you'll find after you get an MRI is stenosis.
Yeah.
What does stenosis mean to you?
That I have no idea. I think it's like a closing of a...
Yeah, so the problem is that stenosis means kind of three different things.
Okay.
There's central stenosis, there's lateral canal stenosis, and there's foraminal stenosis. Basically, the last two are kind of the same. It's just pressure on the side, on a nerve root. Okay?
Okay.
The first one central stenosis is actually pressure on the cord itself, the spinal cord. So if you picture like the tree trunk, that's the spinal cord, and the branches, that's the spinal nerve.
Yep.
Okay? Depending on where you have pressure and for how much pressure and what area that you have pressure will be your symptoms. So if you have pressure centrally, you'll have different symptoms than if you have it laterally.
Okay.
But all stenosis means is a closing down of a hole, but that hole could close down for a ton of reasons too. A ligament could be hypertrophied and get in the way. A bone spur could be in the way. A disc could be putting pressure on the way. Degenerative disc leads to like a collapse of the vertebrae, kind of they get closer together because the discs act like spacers. So that natural hole, that opening closes down. So all of that means stenosis.
Okay, but that all sounds like it would cause problems, no?
It could cause problems.
Okay.
But just like with the disc bulge, it could also not be causing a problem. Or the area that they're looking at on your MRI isn't actually the area that's causing the problem. A lot of this for the low back. The low back, like L4, L5, L5, S1, this always gets diagnosed much more prominently and more often than the other levels. But a lot of patients will have symptoms from other levels, and that's actually the problem. But what you're seeing on the MRI, it looks like it's more of a problem at L4, L5, L5, S1. They're larger, they're a little bit more easy to visualize. So that's what gets told that it's the problem.
So the problem then is if you are diagnosed with a spinal stenosis, it will get blamed for all of the problem. I mean, this is going to be the core theme of all this, right?
It can get blamed for it. It could be causing the problem, right? And if it is, so if it's closing down on it, if a hole is closing down and putting pressure on a nerve, you should have symptoms where that nerve goes.
And you should be able to tell that.
Should pretty much be able to tell that.
But the problem is if it's coming from somewhere else and the symptoms are showing somewhere else, but they see this on the image.
You need somebody to put it together.
Yeah,
you need somebody to put together, and I mean, you spend 5 minutes with your ortho.
Yeah.
A radiologist, a tech does your imaging. A radiologist that you've never met reads it, and maybe they know your symptoms, maybe they don't. Maybe they'll do both. They'll read it without knowing and then reading with, which is probably the way you should do it. Do they write up the report, but do they actually talk to your ortho? Your ortho just gets the report. Does he actually then look back at you and remember your symptoms and then correlate your symptoms with that report? I don't know. If you ask me, it probably doesn't happen as often as you'd want.
Thank you for watching the Spinal Truth Show. I hope you're finding this information helpful. If you're out there and you're still in pain and you're looking for relief, we have some solutions for you. You can schedule a consult with me or a session, but if that's not in the budget, we also have some options that are self-guided at home. You can go to thespinaltruth.com. We have courses set up right now for arm pain as well as for neck pain. They are geared towards you. They are a 4-week course, 60 videos that are self-guided by an expert in the field that you can do from the comfort of your own home at your leisure. They will take you through step by step the typical approach that I take with patients. The expectation is that they will provide significant relief over these 4 weeks. So if you're looking for something better, something different because you're not finding the relief, go to thespinaltruth.com, sign up for one of these courses, and get the right treatment, see the difference.
It seems like you'd be better off just talking to the patient and
you're typically better off just talking to the patient. Yeah, and that's what a lot of people don't understand is that like a lot of these terms, and hopefully that's kind of what you'll see today, a lot of these terms are semi-meaningless. They're just terms. They're kind of like flat foot.
Okay.
All right. Flat feet, about 30% of the population has flat feet. It's not necessarily abnormal, right? So, and if you have flat feet, you can see it. They have flat feet. There's different degrees of flat feet, but you don't necessarily have to have symptoms from having flat feet. Kind of the same thing with all of your disc issues and stuff like that. That just might be you. That might be your disc height. That might be your foramen.
Okay, so, but from a patient standpoint, you're dealing with something when you go and get an image done and it shows something and now you have a title of it.
Right.
It makes sense.
But the problem is that people don't know that it's, again, that it can be present without any pain.
Yeah.
And then they also, they get told that it's a problem, and now they start thinking that they need to protect their back, or their spine's fragile, or there's a problem that needs to be fixed rather than just a cosmetic issue like wrinkles on your skin or bags under your eyes, or I'm just looking at you, but like gray hairs, and I'm trying to pick out hair growing all over your ears and stuff like that.
Yeah, I do got the hair growing on my ear kind of thing going on.
I've found some more recently too.
You just gotta
trim
shave it. Yeah.
It's a pain.
It's a thing. Some people like it,
but I'm not going to get surgery for it.
Not yet.
And that maybe that's the answer.
But
right? You know what I mean?
It's not gonna be pretty, but
that's the whole point. So how about a more common term that isn't necessarily from imaging? How about like military neck? What's that mean?
I don't know. I've heard that. That was the first time I've heard that was here and a couple months ago, and I'm not exactly sure what it is.
It means, I think it's more of a chiropractic use term, military neck, but you'll get a ton of people that they're like, oh, I have military neck, I was diagnosed with this. It basically means a loss of your natural cervical lordosis, so your neck's curve.
So it's more straight?
It's more straight.
Gotcha.
Saw in an image. It's more straight. But remember, like, you're often lying down or you're just in a specific standing position. You're not necessarily your curve during this time. And then finally, it literally means nothing. It means nothing pathologically. There's no symptoms or pathology that typically come from military neck or straight neck versus not. There's not a correlation.
So when someone gets diagnosed with military neck, what do they normally tell them to do? Like, do they say you need to go to a PT and do X,
again,
Y, Z,
it's typically chiropractors that
Gotcha.
I would say the large majority of people that are told that they have a military neck were told by a chiropractor.
Gotcha.
So it's normally, you need to restore the lordosis. So you need to. Most of the time, it's them doing manipulations or adjustments to your neck.
Gotcha.
To realign it.
Gotcha. So, all right, so military neck's one of them. What are some of the others? Did you say does arthritis play into this?
Yeah, so that's a good one that I didn't really think of. And I used to talk to patients a lot about this. But so if you come in and you have arthritis, let's say you have arthritis in your neck arthritis, right? And that's what your X-ray, your MRI showed. Again, you can absolutely have symptoms or not have symptoms from the arthritis. You can get better, but you will still have arthritis in your neck, right?
Yeah.
So, maybe you have some pain from your arthritis or some clicking or popping or grinding or stuff like that, but through restoring normal motion, proper strength, through that range, those symptoms go away. Your pain goes away.
But the arthritis is still
there. But the arthritis is still there.
Yeah.
Yeah, and so I'll tell patients this, look, if you were told that you have arthritis and you have no pain, no weakness, no limitations whatsoever, no symptoms, would you care that you have arthritis? Would you want to get surgery for that arthritis?
Right. No.
No. Okay. Yeah. So yes, you might still have arthritis by the end of this, but we care more about the symptoms, and often the arthritis isn't necessarily causing the symptoms. Arthritic pain, you typically know. It flares up more probably when you eat, a lot of sugar, carbohydrates, cold weather, when you're sick. It's more of just like a generalized joint ache.
Okay.
That tends to be your arthritis pain.
So I feel like a lot of people, I know we have more to go through, but I feel like a lot of people are out there are going to be like, you're just saying everything that is on MRI is crap.
Just shitting on all that. Yeah. What makes me?
Yeah. Why?
How dare I?
Yeah. How dare you?
How dare I? Yeah, so because I'm an orthopedic specialist with 17 years experience, right? I've tried treating patients for these issues. I've tried treating them off of their imaging and off of what the doctor wrote, or just based off of the way that they present, what that would mean physiologically speaking, right? So if you present with pain running down your arm, we're gonna say it's lateral radiculopathy, and we're gonna put this term onto it, blah blah blah, right? So trying to treat just based off of that term, radiculopathy, versus the symptoms, okay? And you'll fail more often than not when you're trying to treat these terms, when you're trying to treat these conditions, when you're trying to treat these pathologies and not treating the patient's symptoms. And that means what they feel, where they feel it, when they feel it, how they move, how they're stiff, how they compensate, stuff like that. That matters so much more. It's what the patient's actually dealing with, their actual symptoms, not just some findings on an image. And B, that typically leads to more meaningful recovery than just cookie cuttering, applying, all right, you said 4 millimeter disc bulge at L4, this is what I do for that.
Yeah.
Yeah.
I can see how you could lose people though, because when you come in and you do all that and they say, well, my pain is in my knee, and you're like, well, let's try this thing on your back. And they're like, well, that's not my knee.
Right. And
even though that would potentially be the real cause.
So when I first started doing this approach, it's a very founded medical approach, subgroup McKenzie physical therapy. They have a similar thought process that I do. And that's where I started this training. Yeah, it was definitely harder to get that point across. Mm-hmm. But most people, if you say, hey, look, we're still trying to treat your knee, but we're going to see if there's some pain coming from your back. And then we're going to see if your knee gets better. Most people will give you a little bit of line to work with.
Gotcha.
But if you don't see that change pretty immediately, and that typically means like right there in that visit, now you are in big danger of losing that patient.
Yeah. All right.
Or them going back to the doctor and complaining, like, you sent me there for my foot, and all they did was look at my back. And
yeah, sometimes it's like when you, I don't quote unquote empower the patient and there's a level of ignorance too, because they're not a doctor, right? But you get a title and your pain is in your knee, and you're like, well, it's because I have spinal stenosis or whatever it is.
Or for your knee, like, I have a meniscus tear.
Meniscus tear, and that's why my problem. But you would think after you go through the whole rigmarole of doing what the typical treatment is and it's not working, maybe then you would consider.
Yeah, you start to think differently. Well, and sometimes you just have to like look, I understand. You have to educate a little bit. Like, look, I understand your MRI said meniscus tear, but did you know that like 40% of the time you had a meniscus tear anyway, and there was no pain from it whatsoever? And they might be like, no, I didn't know. And did you know that like a nerve issue in your back can cause knee pain, and it might not have been screened for? And that's what I'd like to do, so that way, if we move on, we know that we looked at your back and it's not the problem.
Yeah.
And now all of a sudden they're like, okay, well that makes sense. Like, yeah, let's rule out the back. And they don't necessarily understand what that means or anything. But then while we're ruling out the back, I'm seeing if there's a correlation. And again, you map out their knee movement, their pain, you treat the back, and then you relook at the knee. If the knee dramatically changes, now you can start getting more into all right, this is why.
Yeah, and that makes sense. All right, what are some of the other things that people get told?
Tech neck.
That's got to be bent over, looking at my phone.
It's pretty much, it's like the new dowager's hump.
Obviously.
You don't know dowager's hump?
No, I don't know. Dowagers?
Dowagers.
Is that like I have a humpback?
Yeah,
kind of
humpback thing? There.
No, I didn't know there was a title for that. I just call them hunchbacks.
Dowager's hump.
Okay, but that's the same, like, reasoning.
Yeah.
Like bent over, looking.
Bent over. Dowager's hump probably a little bit more congenital, like hereditary.
Dowager's hump, tech neck.
Just from looking down.
Just from looking down, and obviously with like the way we are now, always on the phone.
Always on. Pretty much everybody has some version of it.
Yeah. Okay.
Tech neck is just
it's
a term. I mean, this one maybe your PT is going to give you, maybe your chiropractor.
Like, you got an old-fashioned case of tech neck.
Yeah.
But
a new fashion.
But okay, but if I come to you and I say I have tech neck, I feel like that's probably a good place for you to start.
No, I immediately throw it out.
Oh, really? Okay,
yeah,
it doesn't tell you anything?
Doesn't tell me one. And actually all of these symptoms. So when I talk to a patient, I say, tell me what brings you here. I always kind of start the same way. It's like my little routine. Mm-hmm. As soon as they start telling me, well, I have a herniated, I immediately interrupt them and go, in your own words. I want to know what the patient's feeling, not what they were told they have. You'd be surprised how many people get that wrong, or like I've had so many people like, oh, my hamstring bothers me, and my doctor said this. I'm like, oh, well, point to it, and they point to their quad, and you're like, okay. And same thing with these like terminologies and stuff. Like, look, this was given to you, but you don't understand what it means. You don't understand how it applies. I don't trust that it was given to you properly, and ultimately it doesn't really mean anything anyway. What are your symptoms?
Yeah.
Hey, just a quick break here and then we'll get back to the show. If you're out there and you want to see if this is the right approach for you, you can schedule a consult or a session with me. Go to thespinaltruth.com. At least set up a consult. Within 30 minutes, I will listen to your symptoms. I will go over your history. I'll go over what the approach I would take for you and the results that I would expect. My goal is to save you from continued pain, failed treatments, and prevent you from getting surgery. So go to thespinaltruth.com, set up a consult, and let me go over your symptoms. Now let's get back to the show.
Okay, how about this one? Because this one I kind of liken to if I got diagnosed with congenital heart failure or something, where it's like, oh my God.
Yeah, that one matters a lot more.
Well, I know, but my one-to-one would be degenerative disc disease. I would think, oh my God, things are breaking down in my back.
Yeah, so degenerative disc disease, it literally is naturally aging. Like if you hit 40 and you don't have degenerative disc disease, you're in the 1%. I don't know. It's the rarity, right? Yeah. So all it means is that you're losing disc height, okay, over time. Disc height, your discs actually reuptake fluid at night. So when you get up in the morning, you're technically taller than when you went to bed, okay? As over the course of the day, as your body applies pressure and gravity to the discs lose a little bit of their water, lose a little bit of their height, and over time that's not reabsorbed as much. And there's other reasons, tears and stuff like that you can lose some disc height, and Schmorl's nodes and stuff like that. You know those Schmorl's nodes. Yeah. Modic changes in the end plate. I just love talking about this stuff.
I gotta throw out fun terms just to make you feel better.
Right. So these changes over time lead to degenerative disc disease.
Okay. So if I get diagnosed with degenerative disc disease based on my MRI,
it is not.
Like my back is made of glass and I can no longer do anything.
No, you should be like, okay, that means nothing to me.
Gotcha. I know people who are like, I have degenerative disc disease and spinal stenosis. I can't tell you how many people had like a small fall, right? Like they got pulled down by their dog, or they twisted their ankle, fell down. Like not like a major car accident or something like that, or even a car accident. And then they get an MRI and they get diagnosed with degenerative disc disease. And I'm like, well, that has nothing to do with it.
How do you not put out the only thing that you need to know about degenerative is that it means over time. It doesn't mean a problem, it just means over time. And I think the word disease really throws people, right? Because it is not a disease.
I got like degenerative face disease at that point. Like my face is getting,
So, but if you had a trauma and now all of a sudden it's saying degenerative, like that's not how that works.
And I would think that is the perfect place to use imaging is when you had a trauma.
It is. You absolutely. So there's these rules. There's Canadian cervical spine rule and Ottawa ankle rules and all these like cluster of rules that help you steer somebody towards an image or say that they don't need an image. Okay, but I mean, basically, if they had a fall from a height greater than like 6 feet, if they had a car accident, they always put it in kilometers, so I never remember it, but I want to say like 45 kilometers.
Whoever knows how fast that is.
Whatever, that's not even real numbers. If you can't sit upright, like if you had a trauma and you feel like something's off, you need an image. And that I completely agree with, right? But it's rarely used that way. It's more like, well, I've been going to work the last 6 weeks and nothing happened, but I woke up one day and now my elbow hurts. And they're like, okay, well, let's image it. And you're like, well, this isn't going to help.
Yeah. The other times would probably be for like tumors or something.
Ruling out more like nefarious issues, tumors, space-occupying lesions, like if you're looking in the lungs or something like that. Yeah.
But how often do you get a tumor on your elbow?
I mean, it happens.
I'm sure it does, but like, is that the most common?
No. And so by far and away, and this is what I like to tell people all right, so there's stuff to predict tumors too, right? One of them is age greater than 50.
And then blood test?
Prior history of cancer.
Okay.
Then the third one is smoking, history of smoking.
Gotcha.
The fourth one for me, and I don't know if this would be like the fourth in everybody's order, but it would be failure to respond to treatment over the course of about a month.
Okay.
So if you're going through treatment for whatever you were diagnosed with and like it's really not changing, now you're starting to think like, all right, what could be wrong?
Okay. Makes sense. Or what are some of the other, is there any other things that are kind of common that people?
Sticking with the neck, so the neck has a bunch apparently.
Really?
Cervical instability.
That doesn't sound good.
A lot of people get told that they have chronic cervical instability.
So my neck is all over the place?
Neck is all
Just can't
over the
handle
place.
it?
Yeah. And true stability is rare.
Okay.
And true instability is, it's much more common with a congenital problem, like rheumatoid arthritis, like with a disease or a congenital problem. Rheumatoid arthritis, patients with Down syndrome are more likely to have instability of the neck.
Interesting.
And those are probably the two main ones.
Okay.
So like true instability or trauma, or
Sure.
you had a trauma and now there's some instability. Most people that get diagnosed with it don't have that. Don't have those three things though, or any of those three things.
So far, it sounds almost like these imaging are kind of...
Well, these terminologies, right? And that's why when somebody comes to me, when they give me any type of medical terminology, I mean, I hear it, but I pretty much throw it out. Because I don't want to be tunnel visioned into... So I used to treat people for cervical instability, right? They would come to me, that maybe it was their diagnosis, maybe it's just the term they said. Maybe they heard it from, maybe I didn't even ask, where'd they hear that term from, right? They got it from a friend or the internet or their chiropractor, or maybe it was their DO or whatever. But they would say instability, I'm like, okay, well, this is how you treat instability. And then I'd treat like that, right? Instead of, all right, well, what are your symptoms?
Yeah. Do you think there's an element of Google MDing?
Oh, sure.
This? Okay.
I'm sure there is. But yeah, so like I'll get that question a lot online actually. Where patients will say, like, what do I do if I have cervical instability? And that's why I typically don't respond, because my response is, well, first of all, that's probably inaccurate. So then I'm already in a bit of like a fight with them.
Right.
Right? And then I would say, what are your symptoms? And I'd need to know that in order to know if you actually had it, which you probably don't.
So what about things like carpal tunnel syndrome, which is a legitimate thing? And your thinking is that it's often misdiagnosed.
It's often misdiagnosed, like from the neck. So again, like if somebody comes to me and they say I have carpal tunnel syndrome, I don't necessarily listen to that. I say, well, what are your symptoms?
But would they get an MRI done of?
They could
their
get
wrist?
imaging done of their wrists.
And if
Typically,
that shows something, would that mean?
No, because you can have pressure on the median nerve at the carpal tunnel with and without symptoms.
Gotcha.
So again, like you have to be really careful with these images. The images can show you higher likelihood. They can maybe lead you to an area, but often, and I would say the large majority of the case, they're more misleading than they are helpful.
So why do we rely on them so much?
It's easy.
It's something you can do. It'll show you something.
They're literally the gold standard. Well, all right. So you're going to have two options, okay? And you're going to employ these individuals that have these two options. And I want you to tell me which one do you want to employ.
Okay.
So you're going to have one healthcare provider that asks the patients these questions, goes through a full history, takes a look at how they move, puts pressure on their spine, then maybe applies some treatment and then sees how their symptoms respond after that treatment there in the moment. It takes him, for a first visit, 60 minutes.
Okay.
You're going to have another healthcare provider that listens to a brief history and then orders an image that he'll later get read back to him from somebody else. And it takes him an average of about 10 minutes. And so he can do maybe 4 to 5 of those an hour. Which one do you want?
I own the business?
You own the business.
Well, I do like money.
Right.
Yeah, I hear what you're saying. It just takes a lot longer to really diagnose someone.
To get into it, it takes longer.
Yeah.
Right? And that's the way I think people should be treated, right? Is that proper history, asking them questions, watching them move, pressing on their joints, their spine.
All right, but most PTs, aren't there like initial appointments like 45 minutes to an hour long?
Yeah, but most PTs will treat the way I said, off of the diagnosis from the doctor, off of the diagnosis from the image, which is often the same thing, or off of the terminology that the patient was given along the way.
So if I go to a PT and I say I have, I don't know, carpal tunnel or whatever, do they already have a kind of a whole treatment plan?
This is what I do for carpal tunnel, yeah.
This is the treatment plan.
This is it.
Regardless of anything else.
Yeah. 100%.
Would they still ask me, you think, about like my back?
No, I don't think so. I don't think they ask you about your neck or your upper back.
Interesting.
They definitely wouldn't put pressure on it. And maybe if they did screen your neck, they would just kind of screen it based on movement. But you can have full movement and still have pressure on a nerve at your neck. So again, that's why it often gets misdiagnosed.
Well, isn't there an element to also, okay, with insurance and stuff like that, like you can't get a surgery until you've seen X, Y, Z.
Right. So a lot of times they'll get referred to physical therapy in order to quote unquote fail physical therapy. So they're literally told, they'll even call up on their first visit and say, hey, I have to come in for a visit or 3 visits and to fail therapy, so that way, and you're like, okay, well, this is fun. And they never get better.
So you're like, I want to come in and waste your time?
Yeah.
Because you're not actually here for treatment?
They're just there to check that box so that way they can move next down the rung in order to get whatever treatment, or sometimes it's anything from an injection to an image, even like an MRI, or to surgery. Like they're told that they can't have this until they do PT. So.
But why do you think they think surgery is the option?
For
like, so say like someone who says they need to come in to fail. Is there a reason you think why their mentality is that the PT won't be able to help them anyway?
Most of the time, the doctor said, you need this surgery. And then when they try to get the surgery, they come up, either the patient finds it or the doctor's office finds it, like, no, you need this first. There you go. And so, I mean, if you believe everything we just said, right, like that you shouldn't really use imaging for the most part for your diagnosis. And you should be evaluated for about a full hour, at least for your first visit. Now you kind of know that why the medical system is in such a shambles in the first place, because how many people out there, when they first got evaluated, they wasn't relied on imaging, and they got that full hour-long evaluation.
I mean, what do you say to those people out there, though, who are like, well, you just think everything's from your spine?
Well, I mean, I'm literally saying even the things that they say at your spine might not be the problem.
Not be the exact.
And yeah, like I didn't have this spine-centric philosophy or approach years ago. So like I tried all the other stuff, right? And even still too, it's not like if you come in for your knee or your ankle or your bladder or your whatever, your elbow, that I don't look at those parts or ask you about those body parts, right? Like I ask you about the problem that you're actually having, and then we see if the area of your spine that correlates to that could affect it. If it does, we treat it and we see the effect. So like we're still looking at your symptoms, and if there is no effect, then we can move on to your knee, your ankle, whatever.
And you've seen a lot more success in treating.
I've seen a lot more success treating the spine, significantly more.
Yeah.
And again, not treating based off of these terminologies, based off of the symptoms. Like just throw these terms out. They really don't mean anything. And they get in the way. They clutter your thinking. They clutter the patient's thinking. They bias the patient or the provider or whatever. They don't have a lot of meaning.
So have you ever seen a patient and considered they should have an image done?
Oh yeah, definitely.
Okay.
Yeah, I actually referred somebody recently.
And why? Like, why would be a reason you would think?
So she was a young, what sport did she play? Volleyball, I think.
Okay.
And she was having some chronic low back pain that sounded like it was possibly a spondylolisthesis. So it's a slipping forward of one vertebrae and another due to bilateral, typically overuse stress fractures on an area of your back. It's real common at L4, L5, L5, S1, and it's common in the young adolescents who hyperextend their back. So basically she was having back pain that, by the way, I still think was fixable, and especially with what we were doing, but maybe understanding that there's some underlying instability would be helpful.
Gotcha. So I've talked.
So you know what? The short answer.
Yeah.
I suspected trauma. It was trauma over time. It was repetitive trauma, but I suspected trauma, so I wanted to rule that out.
Like small trauma, not like a huge.
Well, so trauma over time, like literally lead to a fracture and then a slippage of one vertebrae on another. So that's bad.
Gotcha.
but it's like small trauma over time. Like it's kind of like a stress fracture, where it's a fracture, but it's not like a
immediate problem.
Yeah.
Yeah. It'll
Well, yeah, like
Yeah.
I don't know. I didn't phrase that well, but
No, I got what you're saying. I've talked before about my dad's journey, and I remember at one point in his treatment, like I think he had like a degenerative disc disease or whatever was also diagnosed, but I think the term bone on bone
okay,
came up.
Well, that's a good one.
And I was like,
So bone on bone is like arthritis, right?
Yeah.
Most bone. So again, I used to treat people based on degenerative joint disease, which is bone on bone, right? And like you said that, I'm like, oh, well, this is how you treat it. It's non-weight bearing. It's open chain stuff versus closed chain. Closed chain typically means more weight bearing, more stress to the joint, so to speak. Open chain, typically non-weight bearing. So like me moving my leg like this is open chain, just straightening my leg. Me doing squats is closed chain. I'm putting weight through it, weight bearing. Again, there's different ways of treating osteoarthritis, degenerative joint disease versus treating like a meniscus tear, okay?
Yeah.
But you have to be careful about that. I used to treat based off of that, and now I know I still treat off of the symptoms. True arthritis has like a ratchet. Like when you go to move your knee, it's like click, clunk, shift, pop. Like it's almost like a ratcheting opening.
like mobility is limited because of that? Or
I mean, like
just
you'll feel it. It just
Okay.
it's hard to describe. But like like when like moving a ratchet.
Yeah,
like
yeah.
Click, click,
Yeah,
click,
you
click,
get that
click.
grind kind of sensation.
Yeah,
feel
that's
for-
true arthritis.
Okay.
That is, and so you asked me, have I ever told anybody that they need surgery or an image? Yeah, when I see that, I'm like, I had one patient a few years ago. It was on both sides, and she was relatively young too. She was like in her 40s, and I was like, that's true arthritis. And like even the doctor told her that, and she was there to try to prolong her as much as she can. But I was like, and we'll try to strengthen around the area and do what we can, but that is true degenerative joint.
And they can treat that with
They can treat it
surgery?
with a total knee replacement.
Gotcha.
That's how you would treat a degenerative joint. But most people that get diagnosed with degenerative joint or osteoarthritis don't actually have the problem from degenerative joint or osteoarthritis. Those are common findings on imaging over time, common degenerative findings.
Yeah. Yeah. And my dad had all like the surgeries, the fusions and stuff.
And how'd it work out?
He's awful. And looking back, like there's so many things he did that maybe probably made it worse, like neck braces all the time and back braces all day, and
all the treatment that you
inversion
get from our
tables
our common, like everybody out there listening to this, they've probably experienced something similar, where they tried bracing neck or low
injections,
back,
all that stuff to
all the stuff that doesn't work, all the stuff that just numbs you to your symptoms.
Yeah, and continued on doing his hard job.
And again, because it's based off of your MRI finding, or it's based off of this term that you're given from the MRI or from the common like colloquialisms, right? But
yeah, I mean, so boil it down. What do we say to the people out there? One, should they get an MRI?
it's tough because it's tough to address like an individual rather than you have to address the group, right? And in general, if you haven't had trauma, fall, car accident, something like that, and if you don't have symptoms that would mean cancer, or a problem like cancer,
Tumor,
like a tumor, lesions, pneumonia, something that you're trying to rule out like that, then no, you probably don't need an imaging. You probably don't need an image, especially if you are just getting an X-ray. X-rays are almost always pointless, except for fractures.
Gotcha. Okay, so I'm out there, I got a problem. My general practitioner says I need an image or an MRI, but after listening to this, I'm like, maybe I don't. So I'm going to go see someone who will screen my back properly.
Yeah.
So who should I go see?
I don't know. It's a hard answer, and we've talked about this before. In general, I think physical therapists that have some form of an advanced degree in orthopedics.
Would a McKenzie physical therapist?
I tend to put the McKenzie physical therapists higher than the other ones.
Okay.
But I mean, there's other physical therapists out there that could be better than McKenzie. But again, speaking in generalities, if you've had this McKenzie certification, and that actually means the actual certification, not that you've been to a course.
Okay.
You get a lot of PTs that are like, well, I've been trained in McKenzie. Like, you went to one weekend course 6 years ago. Like, that's not trained in McKenzie.
Well, do you think I could go to any PT and say, look, I'm experiencing these symptoms. What can I do about that?
No.
Say I'm experiencing something.
No, I know a lot of PTs that like won't diagnose. A lot of PTs that they want you to see a doctor first. I know places that like even PTs have direct referral where we can see you off the street. You don't need a doctor's referral. There's actually like places like hospitals that'll still operate outside of that. They want you to have a doctor's referral, a doctor's script, a diagnosis before they come in.
Okay.
And again, most PTs, when they do look at you and they are trying to diagnose you, they're trying to diagnose you into these boxes, into these terminologies. And I would really recommend trying to get away from that. Like, you have these symptoms. What do those symptoms mean? You know, like what structure is what areas and what structures are the problem? You know, is it a muscle tendon or is it a nerve? Is it a joint or is it a nerve? Is it spinal or is it in the peripheral joint? You know, like that means a lot more to me than is it a herniation or degenerative disc or degenerative joint disease, stuff like that, like osteoarthritis, hip impingement, you know, these terminologies that we use.
Is there any things that, besides like the cancer and all that stuff we talked about, but something on an image that can show up and you can be like, yeah, that's a problem? Is there like any diagnosis?
I'm sure there is. You get some like inflammatory, like ankylosing spondylitis, you know, that any of like those, like showing underlying problems like severe osteoporosis or something like that. But again, all of these are much more rare.
Gotcha. I didn't know if there was like one diagnosis that would be like, yeah.
And again, this is why so if you went to somebody, this is why you need to go to somebody that knows what they're talking about, because there could be signs like you're an older person with a small body frame and you said that like after you sneezed you had back pain and now it's there all the time.
Yeah.
You probably need an image because that is probably trauma for you because you're older, you're more arthritic, and you probably have bone density issues. So you know what I mean? Like, so you need somebody screening you for whether or not you need an image or not. But most people, we just use it way too much. Yeah. We not only do we use it, but we interpret from it, and maybe that's the issue. So use it, and if there's not anything like glaring, then hey, don't interpret from the symptoms and the patient and the movement, not from the image.
Okay, and then I think another important element out there for the listeners are, if you already had the image done and you're diagnosed with degenerative disc disease or spondylolisthesis or something like that, that doesn't mean your back is
doesn't mean you're broken.
And
doesn't
mean
it's glass.
And it can't be.
And to be honest, it doesn't really mean much.
Gotcha.
Because they can all be there without symptoms.
Gotcha. I'm curious. I want to hear from listeners. I want them to leave in the comments. You know, I was diagnosed with this, and how long ago were you diagnosed?
Well, I wonder how
with
many
it?
people were diagnosed with one thing and then later on diagnosed with something completely different.
Yeah.
I'd like to know that, because I bet you that happens a lot. I was first told I had carpal tunnel, and then it was told I had like ulnar neuritis, and then, you know.
And meanwhile, trying to treat it over the years, and yeah.
All right, well, that's our show. You know, hopefully we mentioned and talked about something that you didn't know or that brought a little bit different attention or information to you than the typical medical system. If you're looking for answers or for treatment, you can go to thespinaltruth.com, sign up for a consult or a session with myself. You can see some of the series we put out. Make sure for more content to like and follow us on Instagram, TikTok, YouTube, and Spotify. See you next week.